You have probably heard that cholesterol is some kind of silent killer, but the real life or death moment is not when your cholesterol number goes up. It is when a fragile plaque sitting on the wall of one of your arteries suddenly cracks open and a clot forms right on top of it. That clot is what shuts down blood flow to your heart or your brain. And cholesterol itself is not some toxic intruder you need to wipe out either. Without it, your cells, your hormones, even your brain simply could not work. So instead of asking, how do I get rid of cholesterol? A far better question is this: how do I keep my artery walls from getting beaten up? And how do I keep my plaques from turning unstable in the first place? If you want more no-nonsense, detailed breakdowns like this one, hit subscribe and like. That is genuinely the simplest way to help this channel grow toward 300,000 subscribers. While you are here, point your camera at the QR code on screen and jump into my Telegram channel where I drop simple checklists and practical health notes you can save and actually use. Let me show you what is really going on inside your arteries. Think of an artery not as a stiff pipe, but as a living tube of muscle lined on the inside with a thin, delicate layer. That layer is called the endothelium. It is just one cell thick and it works almost like Teflon. It keeps blood flowing smoothly past it and prevents clots from sticking to the wall. As long as that lining stays intact, cholesterol in your blood is basically a passenger doing its normal jobs elsewhere in the body. Trouble shows up when that lining gets injured over and over again. Every time it gets damaged, your body treats it as a tiny internal wound. Your body does not tolerate open wounds. It tries to seal them. And part of that repair kit is cholesterol, brought to the site inside little packages called lipoproteins. Cholesterol is not the vandal in this story. It is the patch material. The real vandals are the things that keep hammering that inner lining day after day, mostly cigarette smoke and chronically high blood sugar. Studies looking at cardiovascular risk factors keep showing the same thing. Smoking and diabetes together explain the bulk of serious arterial disease around the world. That is not a small detail. That tells you exactly where the fire actually is. Start with smoking. Every cigarette dumps a cocktail of toxins straight into your bloodstream. Those chemicals irritate and inflame the endothelium directly. Picture taking a piece of sandpaper to that smooth inner surface a few times a day for years on end. That is roughly the effect. The lining gets rough, tiny cracks appear, and the wall becomes more sticky. Once the wall is sticky, LDL particles, the cholesterol-carrying particles we are always worrying about, slip underneath that inner layer and get trapped there. The body reads this trapped material as damage and calls in immune cells. Those immune cells gobble up the cholesterol, turn into what are called foam cells, and right there you have the first stage of a plaque, a fatty streak. Diabetes does the same kind of damage by a different road. When your blood sugar stays high for years on end, sugar molecules start latching onto proteins and fats in your blood and in the vessel wall. That process is called glycation. It thickens the blood and stiffens the vessel walls, making them more brittle. Glycated proteins also crank up oxidative stress, basically chemical irritation, inside the artery. Thicker, stickier blood plus a more fragile lining means more mechanical stress, more microscopic tears, and more chances for LDL to wedge itself in and get stuck. Over time, those small injuries and repair jobs solidify into permanent features, plaques sitting inside the vessel wall. Now, at this point, you might assume that the moment a plaque shows up, you are already living on borrowed time. That is not exactly right. A stable plaque is more like a bump in the road. It narrows the artery, which can cut down on blood flow and cause things like chest tightness when you push yourself or leg pain when you walk. But it does not automatically translate into a sudden heart attack. The thing that changes the picture completely is when a plaque turns unstable. Inside each plaque, there is a soft, fatty core and a fibrous cap covering it. The cap is made of connective tissue. Picture a thin lid that keeps the contents away from the blood flowing past. When inflammation inside the plaque ramps up, certain enzymes start chewing away at that cap. It thins out, gets fragile, and eventually it can split. The instant that cap tears open and the inner core of the plaque meets the bloodstream, your clotting system reads it as a fresh wound. It does not care that this wound is inside a coronary artery. It just sees exposed tissue and reacts. Platelets rush in, clotting factors switch on, and a thrombus, a clot inside the vessel, starts piling up on top of the ruptured plaque. Research on plaque rupture, including work published in Circulation Research and other cardiology journals, is very clear about this. Cap rupture followed by clot formation is what causes most acute heart attacks and a large share of ischemic strokes. It is not the slow narrowing on its own that does the killing. It is the sudden blockage from a clot sitting on top of a torn plaque. There is a pattern that keeps repeating itself in cardiology case reports. Someone has 1 or 2 moderately sized plaques for years. They might feel mild symptoms. They might feel nothing at all. Then one day, a smaller, more inflamed plaque tears open out of nowhere, and that one, not the biggest plaque they had, is what causes the heart attack. So how dangerous a plaque is comes down to more than just its size. It is also about how inflamed and unstable it is. That is why 2 people with identical cholesterol numbers can have wildly different outcomes, and it is why you can never read your real risk off one single total cholesterol line on a lab report. Now let me actually pause and talk about cholesterol itself. You have been told it is bad. You have probably been told to drop it as low as possible. But at the level of basic biochemistry, cholesterol is built into almost everything your body does. It is a core ingredient in every single cell membrane. Without enough of it, those membranes turn leaky and unstable. It is the raw material your body uses to make sex hormones like estrogen and testosterone, your adrenal hormones, and bile acids, which your liver needs to break down fats. It is also part of how your skin makes vitamin D when sunlight hits it. The brain, which is a deeply cholesterol-rich organ, depends on it for nerve insulation and for proper signaling between cells. So the goal here is not to scrub cholesterol out of your body. The goal is to manage how it gets shipped around, where it ends up, and how much of it gets stuck in artery walls under bad conditions. That is where lipoproteins come in. Cholesterol is fat-like, which means it does not dissolve in water. Your blood is mostly water, so your body wraps cholesterol up in tiny spheres made of proteins and fats. Those are lipoproteins, so it can travel through the bloodstream. Low-density lipoproteins, or LDL, are the main carriers hauling cholesterol from the liver out to your tissues. Very low-density lipoproteins, or VLDL, are similar but carry more triglycerides on top of that. LDL and VLDL particles are the ones that most easily slip into the vessel wall and feed plaque growth. You also have high-density lipoproteins, or HDL, which gets called good cholesterol. HDL's main job is reverse transport. It picks cholesterol up from tissues and arteries and ferries it back to the liver for recycling or disposal. Higher HDL is generally tied to lower cardiovascular risk, though the story is more nuanced than just HDL good, LDL bad. But as a simple working rule for you, more LDL and VLDL particles forcing cholesterol into the wall, plus more damage to the wall itself, adds up to more plaque. Enough HDL, less damage, and fewer LDL particles adds up to less plaque. There is another player a lot of standard lab panels still skip: lipoprotein A, written as Lp(a). It is basically an LDL-like particle with an extra protein tacked on. A high Lpa is a genetic risk factor. If your level is high, you did not cause that with your diet or your workouts. You inherited it. High Lpa is linked with more plaque and a stronger tendency to clot. Because of that, some cardiology guidelines suggest checking Lpa at least once in adulthood, especially if early heart disease runs in your family. If your Lpa is high, that often shifts how aggressively a doctor will want to deal with your LDL and the rest of your risk factors. So how do you actually move the needle on these lipoproteins and the plaque process in real life? The 2 main levers are lifestyle and medication. Lifestyle first. Large reviews and meta-analyses of lifestyle interventions keep showing that stopping smoking, cleaning up your diet, moving your body on a regular basis, keeping your weight in a reasonable range, and managing your blood pressure and blood sugar can cut your cardiovascular risk dramatically when they are combined. Some analyses suggest most cardiovascular deaths around the world could be prevented with a steady lifestyle change package. That does not mean you have to be perfect. It means these levers carry a lot more weight than any single lab number. On the food side, eating patterns like the Mediterranean diet, plenty of vegetables, fruits, beans, whole grains, olive oil, nuts, fish have been tied over and over again to lower rates of heart attacks and strokes compared with the more processed, sugary, trans fat heavy patterns most people drift into. That kind of eating tends to bring LDL down, bring triglycerides down, and calm down general inflammation in the body. It also helps with blood sugar control, which protects the endothelium. On top of that, swapping time in a chair for time walking, dancing, or doing any kind of steady movement that gets your heart rate up keeps your vessels responsive and your blood pressure better controlled. You do not need to start training for marathons. A brisk walk on most days of the week is enough to make a measurable difference. Now let me get into medications. Not as a you must take this message, but as tools you can understand and then talk through intelligently with your doctor. Statins are the most familiar drug in this space. They cut down cholesterol production in the liver by blocking an enzyme called HMG-CoA reductase. Large randomized trials and meta-analyses in journals like JAMA and The Lancet show that in people at higher cardiovascular risk, statin therapy lowers the chance of major events like heart attacks and strokes over a few years of treatment. The higher your starting risk, the bigger the benefit. That is why guidelines do not just look at your cholesterol number, they look at your full risk profile. Age, sex, blood pressure, smoking, diabetes, family history. Statin side effects are real and worth talking about. Some people get muscle aches, some show elevated liver enzymes on a follow-up panel, and a smaller group reports fatigue or brain fog. In a lot of cases, adjusting the dose or switching to a different statin clears the problem up, but those are calls to make with the doctor writing the prescription. The important thing for you to know is this. If you have already had a heart attack or a stroke, or you have clear plaque on imaging, the evidence behind statins is strong enough that most cardiologists are going to at least put the option on the table. Ezetimibe is the second name worth knowing. Unlike statins, which work in the liver, ezetimibe works in the gut. It blocks a specific transporter in the small intestine that normally pulls cholesterol in from your food and from bile. With that transporter blocked, less cholesterol reaches your bloodstream. A meta-analysis of randomized controlled trials covering more than 2,700 people found that ezetimibe used on its own brought LDL cholesterol down by about 1/5 on average compared with placebo, with side effects close to placebo. That is a meaningful drop, especially for a single drug with a relatively clean safety profile. In real-world practice, ezetimibe gets used in two main situations. First, as an add-on when someone is already on a statin but their LDL is still above target. Combining the two pushes LDL further down than either drug pulls it alone. Second, as a stand-in when somebody simply cannot tolerate statins because of side effects or is strongly opposed to taking them. For a person with elevated LDL but no advanced plaque yet, ezetimibe can be a reasonable first medication to talk over with a doctor. If LPA is low and the main issue is straightforward LDL, that argument gets even stronger. There are newer options too. PCSK9 inhibitors, for example, which are injectable antibodies that drop LDL dramatically by helping the liver pull more LDL out of the blood. But they are pricey and mostly reserved for people at very high risk or with genetic cholesterol disorders. Bempedoic acid and a handful of other agents are in the mix as well. The point to take away is this: you are not stuck with one option. There is a toolbox here. The right combination depends on your actual risk, your lab numbers, what you tolerate, and what you prefer. Let me ground all of this in a couple of snapshots that show up in real medical records. One pattern that comes up often. A man in his late 50s, let us call him Gary, has mildly high cholesterol on every yearly physical for a solid decade. He smokes just a few cigarettes a day, his blood pressure is borderline high, and his fasting sugar sits just above normal. He always turns down medication and tells his doctor he will work on diet, but nothing ever really changes. Then one day he gets crushing chest pain while mowing the lawn. In the cath lab, the cardiologist finds several plaques. The one that triggered the heart attack is not the biggest. It is a smaller, soft, inflamed plaque that ruptured and set off a clot. The note in his chart is simple. It was the combination of risk factors and plaque instability, not the total cholesterol on its own, that almost killed him. Another common story you see in primary care. A woman in her late 40s, let us call her Linda, has had type 2 diabetes for 10 years and no smoking history. She comes in complaining about leg cramps and numbness in her feet. Her cholesterol is only moderately high, but her blood sugar control has been poor for years. An ultrasound of her leg arteries shows significant narrowing. Her plaques have built up mostly because of chronic sugar-related damage to her vessel walls, not from astronomically high cholesterol. Once her care team finally locks in on blood sugar, blood pressure, and LDL together, combining lifestyle changes with medication, her symptoms start improving and the disease slows down. Cases like hers show that fixating on one number while ignoring the rest of the picture is a poor strategy. Now let me turn this into something practical you can actually use. First, if you smoke in any amount at all, that is the single biggest cardiovascular topic to put in front of your doctor. This is not about shame or blame, it is about the simple fact that every cigarette keeps damaging the exact inner lining you are trying to protect. Quitting is hard, but combining behavioral support with medications like nicotine replacement or other stop smoking aids meaningfully improves the odds of actually succeeding based on multiple large studies and public health data. If there is one move that multiplies the benefit of everything else you do, this is it. Second, blood sugar control. If you already know you are dealing with diabetes or prediabetes, treat that as a direct message about your arteries, not just your pancreas. Steady, sensible blood sugar management through what you eat, how you move, how you sleep, how you handle stress, and medication where it makes sense, brings down glycation and inflammation inside your vessel walls. Trials consistently report lower cardiovascular event rates when blood sugar, blood pressure, and lipids are managed together, not handled in separate silos. That is exactly why most current guidelines bundle them into a single cardiometabolic risk package. Third, ask for a proper lipid panel instead of accepting one total cholesterol line on your lab slip. You want LDL, HDL, triglycerides, and non-HDL cholesterol at the very least. In a lot of situations, adding an LPA test once in your life is worth doing, especially if heart disease shows up in your family before age 60. A fuller panel gives your doctor what they actually need to talk you through whether lifestyle alone is enough for now or whether medication deserves a seat at the table. Fourth, if imaging has already turned up plaques, maybe a coronary CT angiogram, maybe a carotid ultrasound, maybe a stent procedure in your history, your goal shifts. At that point, the question is no longer, do I have plaque? You do. The new question is, how do I keep these plaques stable and stop new ones from forming? That usually means aggressive risk factor management, medication to make plaque caps thicker and less inflamed, and often antiplatelet therapy to cut down on clot formation on top of a plaque. Those calls are highly individual, but there is real value in understanding the logic so you can ask sharper questions. Age matters in this conversation too. The pace of atherosclerosis tends to pick up noticeably after 50. The same risk factors that drove slow, quiet plaque growth in your 30s and 40s can drive faster, louder changes later. How old are you right now? Your age affects how often you should be checking your lipids, how aggressively a doctor might lean toward treatment, and how much benefit you are likely to pull out of each intervention. Fifth, do not underestimate the small daily stuff. Taking the stairs instead of the elevator, walking for 20 or 30 minutes after dinner, swapping sugary drinks for water or unsweetened tea, cutting back on ultra-processed foods. None of that makes a flashy Instagram post, but it steadily nudges your physiology toward a less inflamed, less plaque-friendly state. Long-term observational studies and intervention trials keep showing that people who weave these habits into normal life have lower rates of heart attacks and strokes, even when their genetics are not great. So what do you actually do with all this after the video ends? Start by putting together a short list for your next appointment. 1. Ask whether your current risk factors, smoking, blood pressure, blood sugar, family history, place you in a higher cardiovascular risk category. 2. Ask whether the cholesterol testing you have done is enough, or whether a fuller panel including LDL, HDL, triglycerides, and possibly LPA would help. 3. If your LDL is high or you already have plaque on imaging, ask which options, statins, ezetimibe, or some combination, make sense in your specific situation, and what the expected benefit and risk look like for you personally. 4. Be honest about your smoking status, your eating habits, and how much you actually move. Not so you can be judged, but so your doctor has something real to plan around. Your job here is not to walk out with a prescription or refuse one out of principle. Your job is to understand what is actually happening inside your body well enough that you and your doctor can build a plan together that fits your risk, your values, and your life. Everything we have walked through today, from plaque rupture to ezetimibe, is meant to help you ask sharper questions and notice simple, high-impact changes you might have been missing. This is educational content, not a treatment plan, and anything you decide to change about your health is something to work out with a person who knows you, your history, and your actual lab results in detail. If this deep dive helped you see cholesterol and plaques in a clearer way, hit subscribe and tap like. That is how this channel inches closer to 300,000 people who genuinely understand their own bodies. And if you want ready-to-use checklists and quick health reminders, point your camera at the QR code on screen and join my Telegram channel, where I post those extras for you.